Hello, my name is Luis Morelli. I'm a vascular surgeon from San Jose, Costa Rica. First of all, I would like to thank you for the invitation. As being part of Endola Group and as representative of Latin America, it's really a pleasure to be part of Icarus. I hope my lecture will contribute to this great meeting. Our theme to discuss today is about aggressive foot arch, revascularization, and how it's feasible and how it can impact in the clinical evolution of our patients. I don't have any conflict of interest to disclosure, at least not for this meeting or this topic. So the first thing to do, or that I will do, is try to expose how complex and how prevalence is a multi-level disease in our patients. That has been published by Dr. Graziani in 2007 with a very nice paper. And he found that almost in 1,000 of his patients, there were lung occlusion in the tibial arteries. There were lung stenosis also in the femoral popliteal arteries. And he proposed this classification that go from 1 to 7, being 7 the more complex lesions, with lesions at the femoral popliteal with occlusions, occlusions on lung occlusions, and calcified lesions in the tibial vessels, and also a very disease below the ankle arteries. But it's also interesting that he found that in 74% of the cases, they were classified between class 5 and 7, being most of his cases located in very complex disease. So when we think about that and we think about an ideal technique, definitely I'm not allowed to think only about one technique. I consider multiple techniques in the same patient trying to success in this complex situation. So that's why I think our case will show us or try to exemplify how difficult it is and how important it is to have different alternatives to treat the same patient. So this is our angiogram. You can see that there is no femoral disease. There is no neither significant stenosis at the popliteal level, but at the below the knee, we begin to find a complete occlusion of the posterior tibial artery, long occlusion, calcified lesion. There is two vessels that reach to the ankle, almost normal, the anterior tibial and the peroneal. But when you examine a little bit the ankle or the below the ankle arteries, you see that there is no dorsalis pedis, there is no direct flow to the foot arch, there is an area of hypoperfusion in the heel and the plantar part of our patient. So as you can see, again, there is complete occlusion of posterior arteries. There is a very diseased foot with no perfusion to the posterior part of the foot, with very hypoperfused ankle, heel, excuse me, and also in the lateral plantar aspect, there is no arteries. There is no irrigation to the direct irrigation to the foot arch. This is another aspect that I would like to discuss, and I think it's very important. It's about the foot arch patency. I think that is one of the situations that really impact the evolution of patient, and also it oriented us as how to revascularize our patient. You can see in the angiogram that there is areas that are not really perfused, like the heel of this patient, and if we take a look also to the foot, we see that there is also an area of necrosis located in this hypoperfused area. We correlate also with no direct flow to the foot arch that correlates also with the lesion we found in the toe. So it's very important always to look not only the angiogram, but also to look where the patient have the tissue problems or the ulcerations, trying to direct our revascularization in these areas. So our first strategy, or what we proposed first in the patient, was an antegrade posterior tibial artery recanalization. We make an ultrasound guidance puncture of the femoral artery, ipsilateral, and then we work with a CTO catheter and a O14 guide wire into the posterior tibial. That's how we propose to treat this patient initially. We were able to get our wire and our cat in the more distal part of the posterior tibial artery, but definitely when we make that selective angiogram, we were not able to found a lateral plantar or middle plantar artery where we can get our revascularization of the posterior. and we tried to get into the foot arch distally, but unfortunately we ruptured the artery and we were not able to continue in this fashion. So we failed to cross the lesion. Our second attempt was an antegrade dorsalis pedis recanalization. So as you can see, there is a well-developed collateral, a tarsal artery, but there is no direct or patent dorsalis pedis that connects to the foot arch. So we attempt to go to the dorsalis pedis. There is a selective angiogram that we were able to get into the foot arch, but unfortunately what we found with this is an incomplete foot arch that we were not able to cross that small millimeters and connect into the other part of the foot arch to the lateral plantar. So we failed also to cross with this attempt, but then we think about a third resource that is a foot arch recanalization through collaterals. So interesting, the anatomy where was proposing to us a different way or a different path to get into the foot arch. So we follow this collateral carefully with O14 guide wire, and we finally were able to cross into the occluded lateral plantar. So as you can see, there is a CTO cat that is supporting our wire. It's a O1490 wire. It's one of the wires that we use daily. But you can see the difficulty that we have even in retrograde fashion to cross the occlusion. We have to make a big loop in the finally centimeters, but we were able to get inside the posterior tibia that was pre-dilated previously in the antegrade or failed antegrade recanalization. So we dilate the posterior tibial artery distally. We dilate also the plantar arteries and try to connect to the foot arch. And that allows us to obtain now 3 vessels to the foot. As you can see, there is the velocity of the flow is almost the same for the 3 vessels. So we have a very nice outflow. The posterior tibial is getting into the lateral plantar directly to the foot arch, perfusing the heel, perfusing the plantar aspect, and perfusing also directly to the foot arch to the toe. We were able to preserve the collateral. We treat that very carefully, trying to avoid any damage, any perforation or dissection, not even a vasospasm. And finally, we success to give direct recanalization in a patient that needed definitely to have flow to the heel, flow to the greater in accordance to impact clinically of how he will respond to our revascularization. So for conclude, success in complex multi-level total occlusions requires definitely proper tools, knowledge, and experience in different techniques. 90% of technical success rates in very complicated lesions has been reported, and with more than 90% lymph salvage. So that promotes endovascular therapy as a first-line treatment. I think one of the most important things to remark is that you have to correlate the clinical part of our patient, where the lesions are, how ischemic is the patient, and where he's suffering from the ulcers, and try to give the flow the more directly to these areas, and try to also analyze the status of the foot arch is completely important. And if it is not patent, try to achieve or recanalize also these vessels. Thank you so much again for the invitation. Hopefully we'll have some time to discussion. Thank you.